The Trauma Symptom Checklist for Children Screening Form, TSCC-SF, is a self-report designed for adolescents aged 8 to 17. The Trauma Symptom Checklist for Young Children Screening Form, TSCYC-SF, is a caregiver report for children aged 3 to 12. The purpose of these forms is to quickly identify trauma-related symptoms so that the clinician can decide whether a more detailed assessment is needed. They can help clinicians understand symptom patterns after traumatic events like abuse, violence, loss, or disaster, and when used together, they give different information from different perspectives. Both of these tools were developed by John Breer and published by PAR Inc. They are designed to screen children who have experienced trauma, such as physical abuse, sexual abuse, major loss, community violence, peer assault, and natural disasters. These tools are professional tools created for clinical use. While the original forms were developed in 1996 and 2001, the assessments in this presentation are short forms of the original measures. The TSCC-SF is a brief self-report tool for children and adolescents aged 8 to 17. It is a 20-item assessment that takes around 5 minutes to complete and focuses on fear, trauma-related distress, anxiety, and sexual concerns. Some example questions may ask the child whether they feel safe and help identify if further trauma assessment may be needed. The TSCC-SF has strong reliability and validity. Internal consistency, as measured by Cronbach's alpha, ranges from 0.79 to 0.85. The test-retest reliability of 0.80 shows that scores stay fairly stable over time. The validity scores correlate well with the longer version of the assessments and other measures, supporting the conclusion that it measures trauma as intended. Normative data provides a strong normative basis. Standardization was on a sample of 3,955 youth ages 8 to 17. Research shows that the TSCC-SF is reliable and valid. The TSCYC-SF assessment is a 20-question caregiver report screening tool for young children that can be completed in 5 minutes. It contains the same set of subscales as the TSCC-SF with a focus on fears, sexual concerns, and trauma-related distress that caregivers have observed. Like the TSCC-SF, the TSCYC-SF shows strong psychometric support. Both assessments are similar in internal consistency and test-retest reliability. The normative data for the TSCYC-SF was based on a standardized sample that included 750 caregiver reports of children aged 3 to 12, which strengthens the norms. Research supports its validity as scores relate well to other parent ratings of child behaviors. The scoring seems to be straightforward, and each form has 20 items that can score up to 36. The scores are based on a 4-point Likert scale using never, sometimes, lots of times, and almost all of the time. The scores are grouped into general trauma and sexual trauma. Raw scores are then converted into T-scores and percentiles, and the results are then compared to age and sex-based cutoff scores. The interpretation of scores is either normal, at risk, or elevated/clinical. Cultural awareness matters in assessments. Different cultures may express distress differently, and caregivers may interpret things differently. Language barriers and family structure also affect how the items are understood. Since norms may not affect every population well, clinicians should avoid assuming a low score means there is no trauma. It is very important to take this into consideration when interpreting the data. Due to the nature of the questions, ethical consideration is very important. Informed consent must be obtained, confidentiality kept, and children and caregivers need to understand that this may bring up some uncomfortable feelings. Mandatory reporting may be required if abuse is disclosed. Although these assessments have strong psychometrics, there are limitations to keep in mind. These are used only for screening and not for diagnostic purposes. The TSCC-SF does not include validity scales, as it depends on honest responding. Since norms may not fit every culture or clinical group equally, interpretation should be done carefully. Assessments with scores that indicate trauma should have a follow-up clinical interview. A high score doesn't necessarily indicate that the child has PTSD or another diagnosis. The follow-up interviews help determine the severity of trauma, as well as help with treatment planning and referrals, especially if safety concerns or abuse are present. These tools are often used in settings such as clinics, schools, and child advocacy centers. They can be used to support trauma-informed care, can be completed quickly, and can help track changes over time. These assessments matter because trauma is not always obvious. The TSCC-SF and the TSCYC-SF provide a quick, standardized way to screen for trauma-related symptoms, identify possible risk, and decide whether a child needs a follow-up. I chose this particular set of assessments as one of my options because of the population that I currently work with. Too often, when a child is exposed to trauma, it presents in behavior problems, either at home, at school, or both. Using tools like this will help provide early intervention strategies for both the child and the parent. I would use these assessments because they are quick, practical, and useful for identifying traumas. And I also like that they fit well into trauma-informed practice because they help me recognize children who are struggling without needing a long assessment right away. They have strong psychometric support with internal consistency ranging from 0.74 to 0.85, and they showed validity correlations with other trauma-related measures. Overall, I feel like these will help me screen efficiently, guide the next steps, and support early intervention. In conclusion, the Trauma Symptom Checklist for Children screening form is a self-report assessment for children ages 8 to 17, and the Trauma Symptom Checklist for Young Children screening form is a caregiver report assessment for children ages 3 to 12. Both are helpful in identifying trauma-related symptoms, and research supports their reliability and validity. When used ethically and with cultural awareness, they can be useful tools in child trauma assessment. Because they are screening measures rather than diagnostic tools, they work best when used alongside other clinical information and follow-up assessments. They help identify and guide follow-up assessments, referrals, and treatment planning when needed. The TSCC-SF captures the child's perspective, and the TSCYC-SF captures the caregiver's perspective. Utilizing both of these together will help provide more of a complete view of the child's experience. Limitations such as cultural differences and self-report assessments need to be considered when interpreting scores.